disclosure and the barriers faced by service users. The webinar will also cover the evidence for adversity, trauma and resilience inquiry in the UK and the US, drawing from evaluations of the REACH model, which I know you'll hear more about this afternoon. So I just want to welcome Dr. Warren Larkin, consultant, clinical psychologist and managing director at Warren Larkin Associates. Good to have you back, Warren.
Thank you, Sarah. Delighted to be back. I'm just switching my phone off. Should have done that earlier. Shall I kick off, Sarah?
Yeah, over to you. Yeah, that's fine. Thank you.
Fabulous. Thanks to everyone who's made the time to attend. Really appreciated. Hopefully this session will build on what we covered last time. So I'm going to share my screen with you. And now I'm going to turn off the presenter view. So there we go. Okay, so this is really about some key principles to implementing routine inquiry. And every time I talk about this, someone says, but what about the can of worms? So we're gonna get to that. There is no can of worms. We'll dispel this myth by the time we're finished. So just quickly revisiting the fact that adverse childhood experiences are incredibly common, unfortunately. About half the population in England and Wales said they've had at least one of those experiences growing up, and about 1 in 10 people say they've had 4 or more. Some countries the rates are a bit higher, some they're a bit less, but this is pretty ballpark for the kind of global figures. But as you can see, it's almost the majority of people that are affected. There's a really important finding that's carried on for about 25 years, which is whenever there's a population-based study of adverse childhood experiences and outcomes later on, studies have always found this dose-response relationship. So I think there have been around 44 to 46 population-based studies since 1998. And every study that's looked for this relationship, this dose-response relationship, they've found it. So it's a consistent finding. It's not a one-off thing. And what that tells us is that the more exposure you have in childhood to toxic kinds of stress, which are those 10 adversities that have been studied extensively, different kinds of abuse, neglect, loss, household dysfunction, the greater the exposure to those things, the higher the risk of poor physical health, poor mental health, and poorer social outcomes. So ultimately, what we know in a nutshell is that more exposure to childhood adversity increases the risk of adult onset chronic illness, such as cancer, heart disease, type 2 diabetes, inflammatory conditions, addiction, mental health problems, being the victim or perpetrator of violence, struggling in education, having more exposure to the criminal justice system, using more healthcare resources, more emergency services. The list goes on, and none of it is good. What we do know on an individual level is if you've got enough resilience assets in your life, you could experience all 10 adverse childhood experiences that we know about, and you could be perfectly fine in adult life. These studies look at populations and patterns. They don't look at individuals. So if you're sat there thinking, well, I've had 4 of them or 10 of them, you might be absolutely fine because you've had enough resilience factors and safety factors in your life to offset that. So that's something we have to remember when we're thinking about these studies. The weird thing is, the strange thing, the frustrating thing is that despite us knowing that adverse child experiences have a very strong predictive value in terms of working out people's risk for health problems, mental health issues and social problems, we still don't ask about them routinely when someone is seeking help. Sometimes services ask broad questions about, what kind of childhood did you have, or have you experienced any trauma? But rarely do services ask explicitly about physical abuse, sexual abuse, emotional abuse, living in a house with domestic violence, living in a home where a parent is addicted to substances, living in a home where a parent's got a serious mental illness, etc. So this is something that we have to get better at doing. If we can identify people sooner, we can give them the right help sooner. So that's the human cost, but the financial cost is considerable as well. This is a study from Karen Hughes and Mark Bellis and colleagues at Public Health Wales. They looked at 5 different population surveys, and they looked at the evidence linking adverse child experiences and health and social outcomes later on. And they calculated that the cost to the health system alone in England and Wales every year is £42.8 billion, mostly due to these chronic illnesses that could be prevented, in addition to violence and mental health issues and addictions. So when you look at the things that got a really strong relationship to child adversity, and you look at the cost of those things, I mean, we have a really strong case for an investor save strategy. 10% of that £42.8 billion would go a long way towards preventative services. But unfortunately, we spend most of our time and resources picking up the pieces, it seems. Nowhere more so than in the area of addictions, I guess, because ultimately it is about harm reduction very often. And services are commissioned to do that kind of work, and they do it really well. But in terms of people completely recovering from addiction to substances or food or sex or gambling or alcohol, the figures are not that encouraging. So when we look at something like obesity, for example, there are lots of methods and strategies to try and help people live a healthy life and not become ill because of their weight. But when all of those things fail, people are offered things like surgery. So people get bariatric surgery, which is kind of sold as a very successful treatment because people lose lots of weight and they become healthier in lots of ways. But when you look at long-term studies of populations of people that have had that surgery, they have much higher rates of suicidality, they have much higher rates of other mental health problems, and higher rates of other kinds of addiction, because ultimately we're taking away a person's ability to use one particular way of self-soothing and coping, which is food, but you've not dealt with the underlying pain. So actually that person then feels the same discomfort, the same pain they did before, but now they can't use food to soothe that pain temporarily. So they have to find another way of feeling better. And that's the same with all of these things, including, the criminal justice system. We put people who have broken laws, done criminal behaviour into prisons. And very often people don't get the restorative, the healing, the social skills, the social connections that they need to live a more successful life when they come out of prison. So as a result, they often come out of prison more traumatized than when they went in. And it doesn't solve the problem. So we can't just treat the symptoms of a problem without understanding the underlying cause of that comfort-seeking behavior. So maybe treating the symptoms and not addressing the cause isn't a solution because it doesn't seem to be working at the moment. Maybe part of the solution is asking people what happened to them, finding out the source of their pain, the source of their distress, their discomfort, and then helping them make the link between what happened to them and the way that they're coping in the here and now. Address that underlying pain, trauma, discomfort, and then help them find safer and better coping strategies. But unless we do identify the source of the pain, we're just going to continue to treat the symptoms, whether that be physical health problems, mental health problems, violence, addiction. We have to go to the source and see what's driving this. So when we think about this concept of trauma-informed care, lots of people have different views about what it is and what it isn't. But I think a really good place to start is the origin of this term, which is 2001. Maxine Harrison, Roger Fallett wrote this book, top left, using trauma theory to design service systems. They were in Buffalo, New York, and they recognized that their mental health services did not meet the needs of most people because most people had experienced trauma, and that a medical treatment approach was not working for those people. So they said, why don't we stop re-traumatizing people, stop treating the symptoms and ignoring the cause, and actually recognize that most people have been affected by trauma. So that's kind of where this notion, I mean, we could go all the way back to the Veterans Administration in America after the Vietnam War, needing a diagnosis for their veterans, and the inclusion of the first PTSD diagnosis in DSM-3, I think it was. But after that, fast forward into recent history, that book is kind of a bit of a landmark. 2006, myself and colleagues in the UK published, well, colleagues from around the world actually published this book in the bottom left, which really said, we treat serious mental health problems as if they're a brain disease, but actually, the strongest evidence is for life events, traumatization affecting people's mental health and well-being. So we brought together all the evidence that we could find around trauma and the development of psychosis and bipolar problems, presented it, developed an integrative cognitive theory, demonstrated how it could be applied in treatment. Very controversial in 2006, but today some of our recommendations are in NICE guidelines, so it's much less controversial today than it was back then. Another really, probably the most important development in this field was 2014, when in the United States, SAMHSA, which is the Substance Abuse and Mental Health Services Administration, which is a government agency, they published this document, which really legitimized this concept, I suppose. And this definition is widely accepted. So they said a program or organizational system that is trauma informed realizes how widespread the impact of trauma is and understands that there are many different ways people recover, not just treatment. There are lots of ways people find recovery. And they also recognize that there are signs and symptoms to be seen, not just in clients, but it also affects their families and also the staff who work in these services. Service systems can also become traumatized. Organizations can become traumatized and dysfunctional as a result of stress. And actually, the response is integrate this science, this knowledge into policy, procedure, and practice. Do something with it. Don't just kind of go, oh, yeah, we acknowledge this is important. You have to act on it. You have to make it visible and viable by putting it into policy and procedure and training. And then finally, SAMHSA said we have to stop re-traumatizing people, because many occasions in services, we make it worse for people. And there are so many examples of this. We could spend a whole half a day talking about the examples, but I'm sure you've got your own memories and anecdotes of when services have inadvertently added to people's harm. So my view on what are the key things in trauma-informed care, those things that SAMHSA have said, adopting an ethos in the organisation, and SAMHSA offered these 6 principles as well of safety, trust, peer support, collaboration, empowerment and sensitivity. They're all absolutely selected carefully and all in line with the science. Ultimately, they all help people who've experienced trauma. But I've added on prevention mindset, because we've ultimately got to move upstream, identify people who've been affected sooner, help them sooner with the right help, but ultimately prevent some of this stuff. So the things that we do, like health visiting and parenting interventions and social and emotional support for families, all of these things are massive investments in health and well-being. That's where we need to be spending more of our time and money, because that returns on investment. Whereas at the moment, we do most of my career was spent picking up the pieces of traumatic childhoods. Actually, we need to be preventing more of those traumatic childhoods by helping parents and helping families, to do the best they can for their children. So that's an organizational perspective. Then we've got to get better at identifying people who've been affected by ACEs. Not just keep treating them when they turn up at A&E, not just keep treating them when they turn up with addictions and violence and etc., etc. We need to be finding out what's happened to people, helping them make connections between what they've been through and what they're suffering with, and then give them the right help, which means asking the right questions when we meet someone who needs our help. We've also got to get better at promoting resilience factors across the life course. So if I summed up the current system we've got for helping people, it's a focus on pathogenesis. It's all about what's gone wrong and how can we fix it. In the world of public health, this term salutogenesis has been adopted more often, which really refers to this idea of preserving health and well-being in the face of stress and adversity. How do we keep people in a healthy place, in a functional place, even though life's very stressful, even though they might have been through trauma? There's some great material online if you look up if you look up salutogenesis, the handbook of salutogenesis, and Antonovsky, you'll find some really great materials on this idea of social competence and salutogenesis. Anyway, the final thing is some people, it's a minority, it's a small minority, relatively speaking, but some people probably won't get better without trauma-focused therapies. So trauma-focused CBT, eye movement desensitization and reprocessing therapy, these things are evidence-based. I've delivered these therapies to lots of people over the years, thousands probably, but I've also experienced those therapies myself as a recipient. So I can attest to the evidence of these academically, personally, and professionally. And I've seen so many people that I knew if they didn't get that help, they weren't going to get better because they'd spent 20 years in mental health services, trying every medication under the sun, being admitted multiple times and never got better until they got the specialist psychological therapy that resolved their underlying trauma. So that's just a fact. Unfortunately, they're very difficult to access, which is a problem that we've got to address collectively, I think. Waiting to be told doesn't work. I keep meaning to get a t-shirt printed with that on, but the number of times people have said to me over the years, why are you the first person that's ever asked me what happened to me? Right, I've had ECT, I've had 4 different kinds of medication, I've had multiple admissions to hospital, but you're the first person in all that time that said to me, what happened to you? What happened in your childhood? Has anything bad occurred? Have you experienced physical abuse, sexual abuse, emotional abuse, domestic violence, etc.? This is a very, very common situation. People want to be asked, people want to tell their story, but unless it's invited, it's incredibly difficult. There are so many barriers for people to do that. In this study from a charity called Survivors in Transition, who work with sexual abuse survivors, and the University of Suffolk, they looked at the experiences of 608 survivors of child sexual abuse. And they published a series of 3 papers, which are fantastic. This is one of them. I'll be a survivor for the rest of my life. This is another one of them, Denial, Disbelief and Delays. And one of the conclusions that this group of people came to was maybe a solution from the evidence base that we know about is that healthcare professionals could be trained to use trauma-informed models, where asking the question is routine and disclosure made easier, and the response consistent and timely. So one of the things they complained of frequently in this report is their attempts to tell were derailed, they were not believed, and they didn't get offered the right help. So their proposal was, maybe if we take this trauma-informed approach and ask people routinely, it'll be so much easier for them to tell and therefore get the right help. It's kind of not rocket science, but it still isn't happening. There've been several attempts to make this policy and practice. I'll just tell you about the most recent ones. Sort of 2014, 2015, I was working on a secondment with the Department of Health, looking at, well, I think the title was Clinical Lead for Adverse Childhood Experiences, but most of my role was attempting to get the government to adopt policy which would change practice around this. This was around the time of the Rotherham and Rochdale child sexual exploitation scandals, and I was part of a group that was writing reports and recommendations. And one of the recommendations in this report, which basically constituted a promise to change policy and practice, was this idea that we would expand routine inquiries by professionals in targeted services like mental health, sexual health, substance misuse, so that professionals would ask young people and children whether they were experiencing abuse, and then they could be protected sooner and given early help. It kind of makes perfect sense in the context of that child sexual exploitation situation. And there was a second promise that year as well. This came from the Future in Mind report. So this was the Children's Mental Health Task Force that Norman Lamb convened. I was a part of that group, and I was really pleased with the conclusion of the report, which basically said, do you know what? This is so common. Adverse child experiences are so common. Children experience a lot of violence, abuse, neglect, and it has a long-term effect on their health. So why don't we ensure that assessments are carried out in specialist services include sensitive inquiry about neglect, violence, physical, sexual, or emotional abuse? So there was a promise to do that. The government's response in relation to child sexploitation means that routine inquiry in line with NICE guidelines, whereby every young person is asked during a mental health assessment about violence and abuse, will be introduced. So both of those things were ready to be rolled out nationally. I was working on some training and support packages. NHS Digital put all the means and mechanisms in place to collect this data nationally. And then there was an election, and the coalition government was no more, and Norman Lamb wasn't in charge of this anymore. And therefore, literally, it felt like overnight these two things evaporated. Nobody wanted to talk about them, nobody wanted to do anything about them. And the plans to introduce routine inquiry and specialist services disappeared. So we didn't get there, but we've been there. We've been close a few times. So I'm kind of hopeful that in future we will eventually get to that point. So I see the work that we do in this space covers a few areas, and routine inquiry is one part of it. So Sarah was saying at the beginning, frequently people say, oh, yeah, I get what trauma informed is, but what do we do? Like, what are the things we can do? Well, I've kind of faced lots of different common problems in this area over the last kind of 8 years since I left the NHS and started focusing on this full time. And these are the 7 things that I spend myself and my colleagues spend most of our time helping organisations with. This is just to show you that routine inquiry is one part of it. It's not all of it, but it is an important component. The first one is quite often we do like organisational or service deep dives. We kind of establish the current position. What do people know? What's people's attitudes towards this field, this issue of trauma-informed practice? What are we building on? What are the problem areas? What do the workforce and stakeholders think is already happening in line with good practice? And where are the problems? What are the things making service users not want to engage? What are the things that make staff want to leave their job? And what can we do about it? And ultimately, what do you think would be helpful from a trauma-informed perspective for this service organisational system? So it's great to listen. It's like doing an assessment, and on basis of people's experience and opinion, we then create a plan that reflects the needs of that area or place. Then fundamentally, it's absolutely essential to give people foundational knowledge about adversity, trauma, and resilience, just like safeguarding. If you're working with people that are probably affected, you should probably know about it. So I think that should be ultimately part of everyone's basic training. And then, of course, asking people as part of an assessment what happened to them in a sensitive way and responding appropriately has got to be basic good practice. Then once we start asking people what happened to them, they often want to talk about what happened to them. They often want to make sense of it, cope better, do some work on that area. And sometimes they need trauma-focused therapies. But in our experience, most people don't want or need 20 sessions of CBT. What most people want and need at that point is to talk to the person that they've trusted to disclose to, and to be listened to and to be helped to make sense of it. So some basic therapeutic skills are incredibly powerful for a lot of workers out there. There's only ever going to be a relatively small amount of psychotherapists and psychologists. There are thousands and thousands of workers who have lots of opportunity to build relationships with people and to work with them day in, day out. What we found is giving those people a few extra tools, a few extra competencies goes a really long way. So that's another part of the package of what can we do differently. The next thing we have to do is equip our workforce to understand trauma, compassion fatigue, burnout, and how that affects us. Stress-related harms. Most of the time, people seek help when they're already damaged or in distress or in a mess. They've kind of hit a wall. And actually, if we help people understand and identify these stress-related problems sooner and make it acceptable to talk to colleagues and managers about that, maybe people will take steps early on before they reach that burnout point, before they reach that point of being desensitized and just going through the motions and not wanting to do the job. So actually, we've got to get better at protecting our workforce by giving them the right knowledge and ways of addressing that. And then something that I feel incredibly strongly about is this opportunity for reflective practice. So in clinical psychology, it's not an option, it's part of our professional requirement. We have to do it. We have to do clinical supervision every month if we're practicing clinically. Lots of other professions have got some kind of requirement for professional or clinical supervision. Lots don't, though, actually. This is the other thing. So whenever I deliver a training on this subject, we ask for a show of hands, and half the room will say, yeah, I've got some sort of reflective opportunity with my manager, with my peers, some sort of supervision. The other half of the room just look despondent. And you inquire about that, and you find out that they have no opportunity for any kind of reflective or restorative practice. They don't have that group or individual opportunity to step back and think about what they're learning from the work that they're doing. Think about specific incidents, specific cases, work out what went well, what didn't go so well, and actually process really difficult and stressful emotions. One of the things that I always remember is when I was training many years ago, I did an older adult placement. I thought I'd just be doing neuropsychological assessments for stroke and driving and all that. I spent most of my time helping people who'd retired or had some sort of health problem deal with suppressed stress, suppressed trauma. People keep really busy. They have a busy job for 30 years and then they stop because they're sick or they retire. And all of the pressure and all the stuff they've put a lid on just bubbles over, and they have to deal with it. So I think there's something about processing things as you go along. There's something about talking in a safe space with colleagues about difficult, challenging situations, knowing that you're not on your own with that, hearing your colleagues validate you and support you, making sense of it and learning from each other. And there's a lot of evidence that that is a really protective process, that it stops people wanting to leave the job. It improves morale. It improves sense of connection and validation. It reminds people why they chose this profession in the first place. So looking after the people that look after people is a part of this. What do we do about it? And then finally, measuring the impact of what we do, measuring what matters, because often we have like brilliant pockets of good practice, but we don't evidence them so we can scale them up. We just see them as Jane over there did a brilliant initiative in this service, but that's the end of it. We don't learn from it. We don't scale it up. We don't share it nationally. And without evidence, we can't get things commissioned. We can't get things funded. We can't convince people that it's the right thing to do. So routine inquiry is a part of this, but there are lots of different layers of implementation that we need to go through. And we've got evidence for all of those different layers if anyone's interested in knowing more about that. But in terms of this case for routine inquiry, it's pretty compelling. In that study I mentioned earlier, 608 abuse survivors, the average time from the point they started experiencing abuse to the point where they were successfully able to disclose to a professional was 27.5 years. And that wasn't the first time they'd tried. They'd tried lots of times. And that's why the title is Denial, Disbelief and Delays, because that was a common experience. I was kind of a part of that study, but in the background, because I provided confidential information about clinical cases that I'd worked with. And we worked with an economist to calculate the cost of their journey through the healthcare system, from the point where they tried to disclose and were not heard, and then spent however long, 27.5 years on average, getting the wrong kind of help, sometimes getting treatment that was harmful. So we costed that up, and the total economic burden for those 608 people was £3 billion, and each individual survivor, on average, the cost of their healthcare was £4.9 million per survivor. So I can send you the report. It's really compelling. It's much more efficient to give people the opportunity to tell us what's happened early on in their experience, be able to safeguard them, and then be able to give them the right help. And that means the first time they turn up to CAMS, the first time they turn up to their GP with self-harm at the age of 11, the first time they turn up to CAMS at the age of 13 with depression. These are the opportunities that people tell us that were missed. And then John Reed and Alan Fraser looked in 98, looked at their psychiatric unit where they worked in Auckland, New Zealand, and they observed 100 admissions. And what they found was standard practice led to 8% of people volunteering that they'd experienced some kind of abuse at some point in their life. Then they introduced a standard set of questions about physical, sexual, or emotional abuse. The next 100 people were asked those questions routinely. And this time, 82% of people disclosed that they'd experienced physical or sexual abuse at some point in their life. So that's a massive difference. If we ask people, they tend to tell us. If we don't ask people, they're often too scared to tell us. There are too many barriers: shame, embarrassment, fear of not being believed, power disparity. There's so many reasons why there are barriers. When we ask people, they tend to tell us. And then the final case for change is Felitti and Anders' study in 2014. They introduced routine inquiry about ACEs into Kaiser Permanente Department of Preventative Medicine in San Diego. And they had 135,000 patients over the course of 2 years join the healthcare program, the insurance program. Right at the beginning, they have to do a load of health assessments to establish the risk level and the policy fee. So part of that battery of tests, people were offered a conversation about adverse child experiences. They filled in a questionnaire, and then they got to talk to a doctor or a nurse about what they'd written in the context of their wider health. In the following year after that conversation, that 135,000 people used 35% less visits to the doctor and 11% less visits to the emergency room. So that was a multi-billion-dollar implication in terms of savings for Kaiser Permanente. The question is why? Why did they use significantly less resources? Well, Vincent Felitti said, who was the original author of the ACE study in 1998, he said slowly came to see that asking, initially by this inert mechanism of a questionnaire, followed up face-to-face in the exam room, coupled with listening and implicitly accepting that individual who has just shared his or her dark secrets, is a powerful form of doing. So there's something inherently therapeutic or cathartic about having a safe place to tell, often for the first time you've ever told anyone, about what happened to you. And for that person to validate you, to say, that must have been awful. Thank you for sharing that with me. I believe you. Is that something that still bothers you? Do you need help with that? So someone saying, I believe you. And sometimes you get the opportunity to say to somebody, they tell you what's happened and you go, wow, that's, I'm so sorry that happened to you, but that wasn't your fault. That is a catalyst for change. In cognitive therapy, one of the targets of therapy is self-blame, because self-blame predicts not recovering. It's associated with a poorer recovery. So if you can help people see that it wasn't their fault and that this thing happened to them, not because of them, which is often the case when it's childhood, then that can be a massive, massive weight off, a massive liberation. So what we know is that the actual act of disclosure, if it's met appropriately, can be therapeutic. We also know from the work of James Pennebaker, he's researched expressive writing for over 25 years. He's a health psychologist from Texas. And I met this guy 25 years ago at a workshop. I was presenting on psychosis and trauma. He was presenting on expressive writing for trauma. And I wandered into this workshop that he was running, and he'd just done his first major experiment and found that when he got a bunch of medical students to write about their most stressful life events for 15 minutes, 4 times in a row on consecutive days, he found that following that experience of writing about their most stressful life events, their cardiovascular health improved in the following 12 months. Their neurochemistry showed signs of improvement. Their immune function got better. Their stress hormones reduced. They visited the GP less often in the following 12 months. And that experiment wasn't a one-off. He's repeated that paradigm, that writing paradigm, with all kinds of different people. They've shown benefits in things like blood pressure, inflammation, working with veterans, with PTSD, a whole bunch of different categories and use cases. But the principles are the same. And it's a really underutilized technology. But also, we know from the research that actually suppressing emotions is very bad for our health. It's extremely stressful and exhausting. And Gabor Mate wrote a book called When the Body Says No. And he presents a whole lot of case material and a whole lot of evidence about the harmful effects of suppressing powerful emotions. So here's another reason why expressing these deep dark secrets can be health enhancing. I think Catholic Church have been doing this for about 1,000 years, haven't they? This confession business. So let's look at, this is a qualitative meta-analysis of studies between 98 and 2018. And what all of those studies found in common was that in order for someone to be able to disclose, they've got to know it's not normal what's happening to them in the case of children. They've got to want it to have access to a trusted person, usually an adult, and expect to be believed, but fundamentally being asked. So there are two lessons from this. One is we need to teach children about healthy relationships. We need to teach children about their rights using United Nations Convention on Rights of the Child, translated into simple language. No child should be punched or kicked. No child should be left alone for a long time. No child should be touched on their private parts, etc. It doesn't have to be complicated. So they know something's not normal. But fundamentally, they need access to a safe adult who they trust. And that absolutely should happen at school, should happen in the context of sporting activities, that a coach, a youth worker, a teacher, and ultimately, if they're seeking help from services, they should be asked. So there's the conclusion from 20 years of meta-analysis. So for years, I've been working with people affected by trauma, and what I realized pretty soon was it wasn't really common. So I was asking people about their experiences because I just realized quite quickly that it was pretty much everybody I met in psychiatric services. But I realized that wasn't normal. It wasn't kind of standard practice. And I was asked a few times by different services, could we develop some training to help them ask these questions in a sensitive way and respond appropriately? So I developed a training course many years ago, which then evolved. And over the last sort of 20 years, we've learned that there's a reliable recipe, which starts with assessing readiness and buy-in, getting the managers on side in a process workshop, having to understand what helps, what support staff will need, delivering training to staff, which is the easy bit, which usually takes about a day, and then providing follow-up support, coaching, supervision, help to embed practice, and finally measuring the human economic benefits. So this is the recipe, and it works really well. We've got 9 independent academic evaluations. The process is very simple. We remind people about confidentiality and the reason why we're asking these questions. We offer them the choice and the opportunity to take part. They complete a questionnaire, or we sometimes use the interactive card deck to find a different way of having this conversation. Then we offer a compassionate, validating response, and then we agree next steps. Do people want help? Is it still happening? Do they want to talk more about it? So it's actually very contained. It's not therapy. We're not digging into details. We're just trying to acknowledge if something's happened and if it's still affecting someone and if they need help or they need safeguarding. We also teach the principles of how to respond well to a disclosure based on clinical experience, but also based on the testimony of survivors. And the short list is this: say thank you. Someone's trusted you with something they've never told anyone else before. Very often it's a big deal. Say thank you. Secondly, service users tell us they fear that they won't be believed. So say, thank you, I believe you. Say to the person, I don't need all the details. I'm just trying to acknowledge whether something's happened to you. And that's often a relief. People don't want to go into the details. Ask if it's still happening, because we have the duty to safeguard people. And then ask if they think it's relevant or troubling, because they might have dealt with it. They might have processed it. They might have had help already. Most of the time, people haven't, but don't assume anything. And acknowledge their resilience and their amazing ability to cope, and ask if they want any further help or if they want to talk again. Most of the time, people want to talk again. They want to make sense of what happened. They've got lots of questions, things come back to them, pieces of information fall into place. They want someone trusted and safe they can talk to. And then check if they're okay to leave, if they're going back to a safe situation, and agree a follow-up contact. So this is when you know good practice. It's not complicated, but it does need to be planned. Different kinds of questionnaires that you can use. The one on the left, we developed with Department of Health in 2014 and 15. It includes child sexual exploitation questions, which I think is the only questionnaire that does that. The one in the middle is the one they use in California in their statewide program. And the one on the right is the World Health Organization questionnaire, which is translated into many different languages if you want to go on the WHO website. The one in the middle is translated into Spanish as well. I mentioned the fact that we developed an interactive way of doing this beyond the questionnaires, and I'm just going to play this 240-second video for you. So this is just another way of having a conversation. It's just another structure. Questionnaire is really helpful because it's clear, it's consistent, it's explicit. And when you look at studies, you get higher rates of disclosure from questionnaires than you do from a verbal method. There haven't been any studies of the cards yet because they're relatively new, but feedback from various services we've tested them with and who've been using them is that they love the creative opportunities that it provides, and it feels a little bit less direct than using a questionnaire, and it can be kind of what's the word, broken up into chunks. You know, you can do one conversation around what happened, another conversation around how's it affected you, and then looking on the positive of the resilience factors and the sense of direction. So this is never about scoring. This is never about how many aces you've got. It's about, have you had things happen? Have they affected you? And what kind of help do you need? And for the most important thing is it stops us going on a wild goose chase. You know, it stops us searching for the solution to this person's inflammatory condition or digestive problems or relationship issues. When actually the origin of their problem is actually in childhood. It's just they've never looked there. So this is why I think it's so powerful. These are a range of just some illustrative examples of studies. So the top left, multi-centre trial in GP practices in Lancashire, funded by NHS England, evaluated by Public Health Wales. Bottom left, we did a multi-centre trial of GPs in North Macedonia. Better Start Health Visitors, I'll tell you a bit about that shortly. Deep End GP practices in Scotland, Scottish Government trial with NHS Scotland. And then we've done a regional, or not regional, a county-wide implementation in Nottinghamshire, who are now sustaining that practice across Public Health Commission services. I think this is in its 5th year. Now they've got their own trainers and own champions. So all of the services that are doing this, like health visiting, drug and alcohol services, family service, they're all sustaining this and keeping this going because they've got their own resources now. So very proud of that. I think that's the biggest implementation outside of California at the moment. Just a few insights from the GP study. I pick a GP study because they've got the most limited amount of time, I think, of most professionals. And Mark Bellis and colleagues who evaluated this said this proof of concept report, this was in 2018, provides initial support for the acceptability of ACE inquiry in general practice for staff and patients, but they identified it as a means for improving patient-practitioner relationships and for better understanding the wider determinants of health and well-being, which is kind of the whole point of public health, isn't it? So, they surveyed patients who took part. There were about 250 patients who took part in that limited trial. About half of them completed the follow-up satisfaction questionnaire about how was the experience. Really high rates of approval. People thought the questions were sensible, clear, appropriate. 70% of people thought their appointment was improved because they'd had this conversation. And 80% of people thought that providing this information to a health professional was acceptable. So rarely when you ask for people's approval ratings on things in the NHS do you get anything like that level of approval. You could ask people if they wanted £5 each and you wouldn't get that high level of approval. People have different views, believe me. So we were very pleased with the way this went. And people who were asked in this study who took part, people with 2 or more ACEs had high levels of health problems, which you kind of expect. People with 2 or more ACEs had 2.5 times the rate of asthma, 3 times the rate of multiple chronic conditions, and 3.5 times the rate of mental health problems. Yet 2/3 of people had never been asked by anybody before, and it was the first time they'd ever told a professional. So this is telling us that we need to get better at asking these questions. We need to acknowledge that this toxic kind of stress is contributing to people's physical health problems, mental health problems, social problems, and not only is it having a human cost, but the economic cost is unsustainable. So we've got to get better at working with this. The Blackpool health visitor example, we've done a lot of work with health visitors over the years. It's such a brilliant opportunity for primary prevention. This was a collaboration between Blackpool Better Start and NSPCC. Laura, who did the evaluation, works for the NSPCC. Again, approval ratings, all of these questions received 70% plus approval with a 95% confidence interval. And these are women who are asked about adversity at the antenatal visit 6 weeks before birth. People thought it was appropriate and useful. People felt that it was responded to well. They felt that being asked about ACEs helped them think about preventing ACEs for their children, their yet unborn child. They felt listened to, they felt health visit was appropriate, and they felt that it was done in a sensitive and safe way. So we were really pleased with that. And basically, 59 women were interviewed over the telephone 6 weeks after the antenatal visit. So that they're the headlines. Just some qualitative themes. And again, I'm happy to send this report out. It is just fantastic hearing, how well this was received by women who are about to become parents. So one of the themes was it was relevant and acceptable. The top quote goes, I think it was really important, actually. So many people have experienced trauma when they were little, and it makes sense. Helping to break the cycle. This is the primary prevention. I've had some quite bad stuff happen when I was younger. It just makes me more determined to make sure mine don't have to go through what I did, which is wonderful. And then an opportunity for early help. This last person said, I think it's important that people get a chance to talk about these things. It lets you know it's okay not to be okay, or to still be affected by stuff that has happened in your past. So many people are talking about mental health now, but without the opportunity to really talk about it unless you reach the top level, and by then it's too late. So if you can ask for help, if you can say, I had a really awful childhood and I don't know what good parenting looks like before you have a child, that's an amazing opportunity to stop this from being an intergenerational problem. The evidence from the independent evaluations over the last 10 years is that the training that we provide increases confidence. It's acceptable to staff and service users across a number of different settings. People get access to the right help sooner. They can be protected from harm because we can safeguard them. And we always see, this is a very predictable and very reliable pattern, we see an increase in motivation to make changes, whether that be a parent or an individual. When we do the work with health visitors or family support workers from the local authority, they ask parents about their experiences, and very often they reflect on the fact that their upbringing was not a great model for how to parent children. And very often they say, oh my God, I'm just doing the things that my mum did to me. And actually, I want better for my kids. But if I'm honest, I don't really know what to do differently. And it's at that point people start accepting parenting interventions or group support or more contact. Whereas previously they didn't want anybody from the local authority checking up on them. They develop that motivation to improve things for their children. Very briefly, there's a whole program in legislation in California. If you go to a pediatrician or a GP, they will ask you routinely about adverse childhood experiences. They get paid for it, like doing a flu jab. Gavin Newsom, the governor of California, committed to this because the cost to the kind of the budget in California is they've calculated it to be around 1.5 trillion overall, with 24.6 billion on medical care and 1.49 trillion on healthy life years lost. They've also looked at 9 of the 10 found that ACE has dramatically increased the risk for 9 of the 10 leading causes of death in the United States. So people with 4 ACEs compared to those who have none, twice as likely to have heart disease, 2.3 times more likely to have cancer. Let's just skip a couple. 4.9 times more likely to develop Alzheimer's, and 2.4 times to develop liver disease. So they see that adversity is driving costs around healthcare in the United States, and they have to do something about it. In their program in California, they have done almost 4 million ACE screenings since 2020. They have established that in the 0 to 20 age range, 7% had an ACE score of 4 or more, and in the 20 to 64 age range, 17% of people had an ACE score of 4 or more. They've also had 43,870 professionals complete their online program. And they're starting to see a pattern across the state. This is just for young adults ages 0 to 20, children, adolescents, and young adults. But as you can see from this chart, they're starting to be able to map the kind of density of ACE exposure by county. So they can work out where they need to invest more preventative resources, where they need to do more on education, where they need to provide more services of a certain kind. So it's starting to allow them to be really targeted in what they offer. And the Los Angeles County example is really quite powerful. So the LA Department of Health Services found that by implementing the ACE inquiry, more vulnerable people are getting access to social work, community outreach, and mental health services. They're seeing a better engagement from families with vaccines, child and adolescent care, and preventative health interventions. They've seen a reduction in physical symptoms and depression and anxiety scores in people that took part in the ACE questionnaire. And they've also seen twice as many children be identified as in need of enhanced care, which is essentially a monitoring preventative intervention. So ultimately, in Los Angeles, what they've seen is they've improved the quality of care and reduced health disparities for the most vulnerable people in the course of the period they've been doing this age screening process. So it's early days, but they're starting to see a payback on their investment. And once they've asked the questions, one of the things that they do is offer brief interventions, like making every contact count. They offer the education around resilience. So if you don't know that relationships are probably the single most protective source of support in relation to stress and overcoming trauma, if you don't know that, you don't know that. So if we help people connect to others, to their family network, to their social network, to new social networks, that can be incredibly helpful. If we educate people about the protective qualities of sleep, nutrition, and physical activity, physiologically, but also psychologically, massively important. But if people don't know it, they don't know it. And then we help people understand about self-regulatory strategies and the neuroscience behind things like mindfulness, yoga, breath work in regulating the nervous system. And then access to nature is another often easily accessible way of down-regulating the nervous system and lowering the blood pressure. And then obviously making informed choices around mental health care. So I think we can do more with this. It's rather than assuming treatment is necessary, quite often it's about giving people resources and knowledge and choices. So in summary, adverse child experiences cost 42.8 billion annually to England and Wales, purely in the health system. Trauma-informed care has got to be a part of the solution. We can't keep picking up the pieces and not addressing the cause. If we ask people routinely what happened to them when they seek help, they'll get the right help sooner. So we have to normalise this conversation, like we've done with domestic abuse inquiry and health visiting and midwifery. And like in mental health services, for 20 odd years, every time I saw somebody with low mood, I would agree with them from the first meeting. Is it all right if we just do a quick mood assessment when we first meet? And I'm always going to ask you about hopelessness and suicidality. Is that all right? And people go, yeah, okay. So every time we met, I go, just fill that in. Okay. I noticed that you say on question 3 that you feeling some hopelessness today. And I noticed on question 7 that you say you've had some suicidal thoughts. Is it all right if we talk about that? Yeah, okay. If we make these things a normal conversation, people tell us. And the more they tell us, the more we can help them and support them. When I was first trained in the NHS 30 odd years ago, they told us not to talk to people about suicidal thoughts because there was this idea that you would somehow encourage people to have those thoughts, which is completely untrue. So things have changed, but it does take a while for these things to become normal practice. The routine inquiry approach, the REACH model we developed, is feasible and acceptable across settings. They're doing brilliant work in California. It's becoming normal practice. And what they found is that, like us, we found that this listening, this asking, listening, and validating is a powerful form of doing. And for a lot of people, that's all they need, is to be heard and validated and help make sense of things. Treating the symptoms and ignoring the cause isn't working. We can't just keep doing that. And we have to get better at building resilience assets for people, because most of the time people don't access trauma-focused therapies because they're so scarce. They find other ways of coping, and we have to help them do that better. The services and systems, we need a cross-sector approach. There's no single service that can solve problems of complexity in individuals and families. We need to work together. That's really hard when everyone's really busy. But I remember the last serious incident review when I was clinical director in the NHS, and it was 2 services adult mental health and health visiting who had the same family on their books, but neither of them communicated ever. And as a result, there was a serious incident that led to harm for those children because they were seeing the same family, but they never saw the connection between what they were doing and what they were doing. So we've ultimately got to see that this is a collective endeavor with a common goal. And public health, global public health reviews by like the CDC and the World Health Organization all point to the fact that we know what works, but we just need a cross-sector join up and a longer term vision which invests in prevention. If you're going to do this kind of work, listen to the stakeholders first, involve them in producing a plan, make some basic foundational knowledge about adversity, trauma, resilience mandatory, just like safeguarding. Train professionals that do assessments to ask the right questions, and then people are more likely to tell us. And when they tell us, it would be great if we had a few therapeutic skills and ideas that we could bring to the table for them. And then let's look after those people looking after the people. Biggest risk in health and social care and education and policing is losing the workforce. We can't train people as quick as people are leaving these jobs, and that is tragic. So if we look after people more diligently, do this proactive well-being work around reflective practice and processing stress, people are more likely to be healthy and resilient in their jobs and enjoying what they signed up for. And finally, measure what we do, learn from it, do more of the stuff that works and do less of the stuff that doesn't work. There we are. That's the end. If you want to know any more or follow up on any of the things we've covered, drop me a message. I just started doing a series of videos actually on social media about trauma because I read so many articles that were misleading. Please follow me on social media and you can see the videos. That thing in the corner, what is it? A QR code? Yeah, that's a newsletter that I haven't written yet, but you will get it in the next few weeks if you do sign up. And I promise, I'm so bad at doing these things that you'll probably only get like 2 a year. So there you go. Thank you
Thank
very
you.
much for your attention.
Thanks, Warren. That was really useful and definitely made everything feel much more doable and
Thank you, Sarah.
simpler,
Thank you.
which is we always like things like that, don't we? But everybody's got chance now if they want to ask, make any comments with Warren here or ask any questions. So if you want to put your hands up, I will bring you in. There's a question in the chat, which I'll just go to for a second to give people chance. Should we be thinking about routine inquiry in non-clinical settings such as social care, homelessness services, criminal justice, for example? And I think the question after that was, have there been any evaluations in these settings as well?
Yes to both. We've done a lot of work in all of those settings. And we've got evaluations in most of them. I think one of the first ones we did was a multi-agency implementation in Lancashire with a domestic abuse charity, drug and alcohol service, family support workers in Blackburn who are still doing it to this day, actually, almost 10 years later. We've done this with children's services, educational services, drug and alcohol services, probation, all kinds of settings. Basically, if homelessness, if you do an assessment with somebody who's seeking your help, for me, an assessment is the questions you ask to understand someone's problem and to give you a hypothesis about what you can do to help. So if someone comes to you seeking help in, homelessness service or NHS, family support service, if you do an assessment and there's a possibility they could have been exposed to childhood trauma, then it's kind of ethical to ask those questions. So I would say yes to both of those. And if you want me to send any evaluations, we can absolutely share those with you if you drop me an email.
That's great. Thanks, Warren. We've got Sarah Bullen who wants to come in now.
I'd just like to say thank you so much, Warren. I was at your first session, and this session's absolutely brilliant and
Oh,
really
thanks, Sarah.
valuable. I just wanted to ask, I think this is a bit of a stupid question.
I'm sure it
I'm a,
isn't.
I'm a children in care nurse, so my age, the children that I look after are age 16 to 18. So they've come from abusive background,
Yeah.
ACEs, and they're coming into care. So I wouldn't necessarily ask these routine questions because I'm already aware of them. But at the same time, I feel like I need to, as you said, like acknowledge the child and young person's experiences. I'm already writing notes about for my health visitor colleagues, but I'm just thinking for
Yeah.
my own caseload.
I think there's a difference between knowing in the case notes that someone's experienced previous adversity and a conversation that says, how did that affect you? What does that mean to you? And have you had any help for how it's affected you? That's completely, because quite often we know it's in the records, but we have no idea if a person's received appropriate support, things that they found helpful, whether they've actually had no support for that. So just the fact that we know it's happened tells us not a lot about how it's affected them and what kind of help they've had. So I think that's where the cards I think are a really good a good tool, because it's less direct, it's more exploratory if you want it to be, and you could also use it as an educational resource as well. So rather than asking direct questions, you could kind of use it as a an exploratory learning conversation that might prompt a conversation about it. But yeah, I do think it's definitely, the question is it still affecting you? Have you had the right help, and do you want the right help?
Lovely. Thank you very much.
Thanks, Sarah.
Thank you. We've got Alice who wants to come in next.
Thank you. Yeah, I work in children and young people's public health, so I'm kind of interested in it as a screening tool. And I was wondering if there's any processes or advice around if ACEs or trauma memories are like suppressed or not. Yeah, suppressed, I suppose, or repressed, and like around asking it maybe on more than one occasion, or
Yeah,
I don't know, just what your thoughts are, advice on that.
No, Alice, that's a really good point. So what we always say is record this. If you ask it routinely as part of your initial assessment, for example, it might be that that person's still trying to work out if they can trust you. So they might not want to tell you right at the beginning, but right at the beginning is the best place to start asking, because you should demonstrate to people that we're interested. This is what we ask people. We're not fazed by this. This is kind of quite common. They might not be quite ready to trust you, but actually, if you revisit that assessment in, lots of services do 8 weekly, revisits to the assessment, or 3 monthly reviews, whatever it is, bringing it back up and saying, we know not everyone's ready to talk about this right at the beginning, or it might not feel comfortable. However, now is another opportunity for us to talk about this if that's something that will be helpful to you. Very often I've had people that I've been working with for like 6 months, and then on our last meeting, where we're doing our ending bit, they go, well, there's something I haven't told you. So, okay, what is it? Quite often as they're walking out the door, actually, on a Friday afternoon.
Isn't that called like doorknobbing or something?
Yeah, I'm sure there's a term for it, but that's great, because and actually it might not even be you. It might be that they move through the service and meet someone else and go, do you know what? Alice mentioned something to me a while ago, and I've just suddenly realised that I think it's important that I talk about it. So you've kind of introduced the permission and you've made it clear that this is okay for us to have this conversation. So asking at a repeated interval is absolutely appropriate and helpful.
Thank you. I've got Lynn now who wants to come in.
Thanks so much, Sarah, and also Warren, for that talk.
Thanks,
So my
Lynn.
role is I sort of act as a bridge between local authorities, so councils, and also researchers, trying to get evidence into practice and do knowledge mobilisation, that sort of thing. And I wanted to ask, you've referenced a number of different reports and evaluations that have been done. If we were going to go away from this talk and there were one or two sources of information that were focusing on evidence, evaluating the sort of, especially the sort of kind of very brief advice or very brief routine inquiry type model, and the questionnaires you mentioned, is there a particular one or two sources that you recommend to you that we could share, just because obviously sometimes when you've got too many sources it becomes like, what do I look at?
Sure.
So if there was something that was like maybe looking at interventions delivered by different sort of groups and evaluated independently, that would really help me like have something to share.
Yeah, who's your audience that you want to share them with again? Sorry.
So it would be people who work in local authorities.
Okay.
So, for example, people who are involved in like commissioning early help services, or officers who work as like health visitors, or that sort of audience.
Yeah. Okay. So there aren't many people doing this work, to be quite honest. Public Health Wales did a couple of trials with one with GPs, one with health visitors. We've got, I think, 8 or 9 independent academic evaluations across lots of different settings. And then you've got the California model, which has got a number of different audits, plus their kind of regular monthly data reports. So I think you've got those sources of information. If you do a literature search, you'll find various papers debating the subject. And I've also got colleagues in Scottish Government who oversaw the trial that we did that never got published because of COVID, which is the story of my life. But yeah, there are a couple of them. UNICEF in North Macedonia might talk to you about the work they did as well, with lots of different GP practices. So yeah, I think in some sectors it's seen as common sense, like in first episode psychosis, which is where I worked for many years. It's just kind of seen as part of your assessment, right? It's not controversial. It's not even rocket science. It's just standard practice. The rates of trauma in this population are so high. It's in NICE guidelines. We ask them what happened. In other sectors, it's maybe not as common. But I think evaluations, the ones that I've mentioned, I think are probably the best things to look at in terms of learning. Liverpool John Moores recently published the process evaluation for the work we did in Nottingham over the last sort of 5 years, which basically says if you want to implement this across a whole county, what are the factors you need to take into account? So actually, for your purposes, that might be quite helpful. But yeah, if you drop me a message, I'll try and link you up with the right information.
That'd be fantastic. I'll have a Google as well. Thanks so much.
Yeah, thank you.
Thank you. We've got a question from Matthew in the chat. What he's saying is, what's the approach for trying to make trauma-informed practice a common practice across local authorities? I think what he's trying to say that it probably feels easier to do if you're in traditional areas like social care, for example, but is there a case to be made for making local authorities trauma-informed more broadly?
Yes, there is definitely a case for it. In fact, recently I did the collaborative inquiry approach that I mentioned as part of the methodology, where we do the deep dive across all stakeholders. We did that exercise with a local authority with 7,000 staff, and ultimately what we found out was the things that they understood already about trauma-informed practice, the pockets of good practice, the fact that there was a vast majority of staff who had no idea what this was, the fact that it was not evident in the culture and leadership culture that they understood this or applied it, and that actually their biggest problem was workforce, and stress-related problems, turnover, sickness, retention, recruitment were all problems, and all of those problems were exacerbated by the culture. So absolutely, there's a case for looking at the organization itself and the way it operates and the way people are looked after and the way people are treated and included and collaborated with, 100%. But the only way you really get to do that in a way that is inclusive and collaborative is by listening to the people, first of all. hear their testimony, their experience, their wants and needs, and then respond to that with, okay, you said this, we're going to do this in response. So we've got a plan for the organisation to become trauma informed, and it reflects your views and experiences because we listen to you. But my advice would be, don't do that unless you're going to commit to making changes based on what you've been told, because it will damage your relationship with the workforce. Better to do nothing than to promise that you're going to listen and do something and then not do it. That kind of sounds obvious, but I've seen it happen, unfortunately.
Yeah, I've got another one here in the chat as well. Given the research about ACEs, why do you think that mental health support teams in schools don't work with trauma?
Oh God, that's a good question. I think it's all about thresholds, isn't it? And criteria about what's in and what's out. You know, so a mental health worker in a school has got specific competencies and specific training. And whilst I don't know exactly what their training is, I imagine that it's seen as outside of their competences. And if they ask about it, then they're going to have a problem on their hands. This is where the can of worms comes in. Whereas I always say there is no can of worms because the person that you're asking already knows what's happened to them. It's not a surprise to them. They're choosing whether to tell you. You're the one that's worried about the can of worms. So I also think that clinical help for trauma-related problems is incredibly hard to get access to.
Yeah.
So if you turn up to your GP tomorrow and go, right, I've got symptoms of PTSD, I experienced, physical abuse when I was a child, and it's still troubling me, your chance of getting sat in front of a clinical psychologist or an EMDR therapist, maybe, but it might take you a year, it might take you 18 months. And before you get to that person, you might have to see 3 other people in a stepped care kind of model. So one of the biggest problems is we're prescribing antidepressants and psychotropic medications for people who've got trauma-related issues, not because that's ever going to work. Well, it might help relieve some of the symptoms, but it's not going to resolve the underlying problem.
Yeah.
The reason that's happening is because people have not got access. GPs don't have equal choices about what they offer people. They can go, you can have this prescription today, and it should hopefully help you, but you can also have access to this psychological therapy, but it'll be 18 months.
Yeah.
That's not equity. It's not parity of esteem between physical and mental health. If we broke our leg and we had to wait 18 months to get it fixed, we'd be marching down to Westminster, wouldn't we?
Well, we wouldn't with a broken leg, but I know what you mean.
No, that's a good point, Sarah. Yeah. We'd be on a...
And interestingly, I've attended a national group with the Secretary of State for Education with schools about mental health. And what the teachers said to us and the head teachers was they really are afraid of mental health in terms of if a child approaches them with an issue, what they're worried about is making it worse by trying to do something they don't feel competent in doing. And the biggest fear for them is if they don't respond in the right way, they're going to make a bad situation worse, or that child's going to walk away feeling worse than before they came to talk to them. So I think there's something about how do we help teachers, because they're often the trusted person, feel better about some of the easy things they can do to help, because like you say, you don't want to start something you can't finish or to make anything worse.
I 100% get that, and I hear that a lot. In fact, I can't remember if we're going to do a session on this, but we've delivered interventions into 100 secondary schools, 50 in the control group and 50 in the intervention group, in a trial, randomized control trial funded by the Youth Endowment Fund. So we applied trauma-informed interventions program into 50 schools and the other 50 were control. And one of the things that we've done is exactly that. So we've tried to equip teachers, pastoral inclusion leads and senior leaders with more skills, more knowledge, more therapeutic capability, so they can do that basic pastoral care better, that basic relational well-being work, without fear of making it worse, so they can be more relational.
And there's the point in the chat about the government's rolling out mental health support teams, but they're not thinking about what competence is needed necessarily, or how those people will deal maybe with some of the things that they're finding, because the longer people wait for support from
Yeah.
Those specialist places, the more people who are not trained have to pick up, isn't it?
Yeah, and pastoral staff in schools tell us all the time that they're working beyond their competencies because they're not getting enough support or access to CAMS or social care or, you know, criminal justice support. They're like the one-stop shop. You know, they're trying to deal
Yeah.
with everything, and they feel not abandoned, but they feel kind of a bit set adrift from the agencies that are meant to be picking up these young people with complexity and their families. So not surprisingly, they're feeling overwhelmed and burnt out, and
Yeah.
then eventually they clear off and go, I can't do this anymore.
I'm just
So
going to end up. Yeah, sorry, carry on.
no, I was going to say, I think partly is the historical underfunding of CAMS relative to
Yeah.
adult mental health and physical health services that needs
Yeah.
addressing.
I'm going to end on one last thing. Where and how can we signpost people to support, or can we signpost people to support if we need to?
Yeah, I think going back to basics, I would say that if you're struggling with unresolved trauma and you've had a potentially traumatic life event or highly stressful life event, and you've been experiencing intrusions, flashbacks, high levels of arousal, hypervigilance, mood disturbances, relationship issues, feeling on edge, avoidance, wanting to avoid reminders of it. So if you've got any of those post-traumatic symptoms, if things have not got better after about a month, the NHS recommends you go and see your GP or speak to your mental health specialist. They'll adopt a watching brief. They'll keep their eye on things because you don't intervene too soon. Things can take months to resolve, but it's a natural process like bereavement. You know, it's a process, not an event. And they'll keep their eye on things, give you the right treatment options if you need it. There are other places you can seek support. There are lots of charities out there that offer therapeutic help. Survivors charities, lots of organisations who provide free help and free support. It varies by place to place, of course. So often your GP is a good source of knowledge around that. Your health visitor, if you've seen a health visitor, should know about that as well.
Yeah.
Then there's online services like Kooth, KOOTH. If you're a young person in most parts of the country, you can get free access to a qualified counsellor via Kooth, and it's all anonymous, all typed, and it's very liberating for young people because they can be completely who they want to be without fear of any kind of judgment. So if in doubt, seek professional help. You've also got Samaritans and people like that as well.
That's great, thank you. And as usual, we've generated a lot of discussion, and it was a really good and interesting presentation. So thank you, Warren.
Thank you so
We
much.
certainly look forward to your next session, and we will be circulating the date for that very soon. And there's an evaluation in the chat if people wouldn't mind completing it. It's very short, and it just helps us all to get things right and make sure it's what you all need. So just to say thanks very much, and thank you everybody, and hopefully we'll see you again at the next one. Thank you.
Brilliant. Thank you very much. Thanks, Sarah.
Bye-bye.
Thank you.
Thank
Much
you.
appreciated. Georgina, well, can you possibly save the chat for me and send it to me?
Yeah.
Oh, brilliant.
Awesome.
Thank you. Because obviously I've not had a chance to read all of it right now.
Yeah, I will do that.
Wonderful.
Recording.
Okie dokie.